This is a similar type of data that's just come out from Israel, and again using kind of fairly big numbers now, 180 inflammatory bowel disease patients who have a license to use medicinal cannabis in Israel, and we have some good data on how much they use, which is very informative for those of us who are trying to build clinical trials off this kind of data. So the average dose is about 30 grams a month, which is equivalent to about 20 milligrams of THC and 170 milligrams of CBD per day. This is what these patients are typically using. And they found in this study, and this is an observational study, so it's not a control trial, but the patients who are using medicinal cannabis did see a significant improvement in this Harvey-Bradshaw index of symptoms, which is an aggregate of many symptoms. What was interesting that came out in this data, which we haven't kind of seen yet, is that the patients who were using cannabis did have an average weight gain of 2 kilos within the year, which if you're an IBD patient is a beneficial thing, because they often can have significant weight loss because they can't eat, or they have too frequency of bowel motions. So so this is the first indication that not just are things like pain reduced or stress and anxiety reduced, but you can have a kind of an ongoing physical benefit of weight maintenance. And again, this study showed that there was a reduced need for other medications. So this is data that's kind of consistently coming out of different studies. And this graph just show, this table just shows the data on the weight. So people who had a standard BMI had a significant increase in weight, although those who were obese, and this is a very small number, so it was only 5 patients, actually saw weight loss. And again, in an obese population, this could be a beneficial thing. So this is something that needs to be followed up on the kind of long-term effects of medicinal cannabis on weight maintenance in patients with inflammatory bowel disease. And I can't help but highlight some of our own research. This is a study that we published last year, which is on the effect that CBD can reduce gut permeability. So I mentioned at the beginning that one of the problems in inflammatory bowel disease is that your intestinal barrier breaks down, and so things that are in your intestines, like bacteria and toxins, can leak back into your body, which is a bad thing and can lead to systemic inflammation and sepsis. And so we've, in my research group, we've done a lot of work on looking at how cannabinoids can modulate intestinal permeability, and very recently did this study in humans where we caused the gut to be leaky by aspirin, which is kind of well known to cause an acute, short-lived increase in gut permeability. And we looked at whether or not a single dose of either CBD or PEA, and they were both given orally at 600 milligrams, could prevent that gut leakiness caused by aspirin. And we measured it by looking at the occurrence of blood sugars in urine. And what we were able to show was that both CBD and PEA are very effective at reducing gut permeability and stopping that leakiness. And so in a chronic treatment, that could be one of the reasons why cannabinoids, specifically CBD, are beneficial in inflammatory bowel disease by helping to restore that intestinal barrier. So if we summarize that clinical data now in inflammatory bowel disease, where are we at? Where do we think we are in the hierarchy of evidence? So in my opinion, we are in the yellow area. So we have some randomized controlled trial data, which is positive, but they're small trials. They're not big trials. I think the biggest one was the colitis trial, which had only 60 patients, half of which would have been on the active treatment. So we really need to see this being proven now in bigger trials at the right dose, measuring the right primary endpoint. So the clinical trial data does support both the use of CBD and THC. So both individually have been shown to be effective in inflammatory bowel disease. What hasn't been examined yet is whether or not various ratios of these compounds will be beneficial, or exactly what their ratio is that we might want to try and get to get a combination of the analgesic effects of, say, THC with the anti-inflammatory effects of CBD. We do need larger randomized controlled trials to build on this and really move us up the triangle of hierarchy of evidence. Some of the interesting data that's come out from the observational studies is that cannabis use is associated with reduced hospital stays in IBD patients and reduced hospital charges, and also that cannabis use in patients for whom it works is associated with reductions in all of their other medications that they would typically be on, so their analgesics and their immunosuppressants. So this is all pretty positive data to suggest that we need to investigate this further. So I'm going to go on now and talk about what is the scientific evidence that supports this clinical use of cannabis-based medicines in inflammatory bowel disease. So what data do we have from animal studies, and what is the mechanism of how these compounds work? So I mentioned that the endocannabinoid system is very, very well expressed in the gastrointestinal tract. The figure on the left shows you a cross section through your gut, and you've got this green area, which is your the barrier that I was talking about. This is the barrier between the inside of your gut and your body, and then you've got various layers of muscle which control the function of your GI tract. And the picture on the right basically shows you that at every level, at every layer within your gastrointestinal tract, there is expression of the endocannabinoid system. Particularly the CB1 receptor is very, very well expressed on the nerve fibers that innervate the gut and on the barrier, the lining cells of the gut. And also CB2 is very well expressed, and it's been shown that in times of damage or gut inflammation, that CB2 becomes upregulated and becomes expressed at higher levels when the gut is damaged. And so this is part of the reason why cannabinoids can be beneficial in the GI tract, and also part of the reason why we get a lot of side effects associated with the gastrointestinal tract with cannabis-based medicines. So through years and years of research, we can kind of summarize some of the actions of cannabinoids that we know throughout the GI tract. So CB1 activations, kind of starting at the top, we know that it relaxes the sphincters, so the muscles that control entry and exit in and out of the stomach. CB1 activation reduces gastric acid secretion and gastric damage, and it also slows gastric emptying. And in the intestine, CB1 activation decreases intestinal motility, so how much kind of churning and movement of those muscles you have. It decreases intestinal secretions and visceral pain, so that's pain in this organ. And CB1 activation decreases inflammation and the growth of tumoral cells. And I've added in there that it also decreases vomiting, which is also known as emesis, although this arises more from actions of the CB1 receptor within our brain, within that kind of the area of our brain that controls vomiting. And then in terms of what we know for CB2, we know that CB2 also decreases visceral pain, so pain in the gut. It also decreases inflammation and has a very important role there. It's upregulated when you have gut inflammation. And it also decreases intestinal motility when the guts are inflamed. So when you have IBD, you have increased motility, and that's all decreased by CB2 activation. And CB2 has also been shown to decrease emesis, so vomiting like CB1, and also there's evidence to show that CB2 activation can decrease ulcer formation. Now we know a lot about CB1 and CB2 in terms of the actions of cannabinoids in the gut, but there is also contributions of some of the other receptors that I've kind of mentioned over the past few lectures. So cannabinoids don't just act through cannabinoid receptors, but they act through a whole variety of other ion channels like TRPs, nuclear receptors like PPARs, and then other receptors like serotonin receptors, and then these orphan GPR55 and GPR119. All of these receptors have been also shown to contribute to the actions of cannabinoids in the gut and the beneficial actions of cannabinoids in the gut. And the kind of balance of which cannabinoids act through which receptors kind of depends on the compound that you're looking at and its specific pharmacological properties, because all of the cannabinoids, phytocannabinoids, endocannabinoids kind of have a unique fingerprint in how they work in the body. So something that I did a few years ago was did a systematic review of all of the literature that was out there that shows that cannabinoids are useful in gut inflammation. And so this was really in animal models. We don't really have great animal models specifically of Crohn's disease, so they do tend to just be gut inflammation or called colitis. So this is really a systematic review of the use of cannabinoids in all kind of forms of inflammatory bowel disease. So we systematically went through the literature and we identified every publication where a cannabinoid was given and in vivo, so as a treatment in an animal model, and to collate all that data and do a meta-analysis as to which worked and which worked best. And at the time that this was done, which was a couple of years ago now, we found 53 research papers that had looked at this. So 53 different independent animal research studies had looked at the effect of cannabinoids in inflamed gut disorders. And we looked at all of the different compounds that have been looked at. So if you look at the far left-hand side there, you can see that there are endocannabinoids that have been looked at. Palmitoyl ethanolamide and anandamide were both found to be very effective at reducing disease activity score in animal models with total numbers of about 130 animals. CBD is actually the most studied compound. So if you look at the number of studies and number of animals that have been used looking at CBD as a therapeutic option in IBD, 12 studies have been done, and they showed a significant benefit of CBD. Far fewer research, actually animal research, has been done with THC alone, and actually the data was not significant with THC, but I think this is because for some reason as a compound it hasn't been very well investigated in IBD. But there was a whole range of other compounds, synthetic, either CB1 agonists or CB2 agonists or enzyme inhibitors or transport inhibitors, a whole range of different cannabinoid modulators or direct activators were all found to be beneficial in experimental colitis. And when we looked at the total, the sum of all that data, so just looking at all cannabinoids together, you can see that there was a very highly significant benefit of cannabinoids in experimental colitis, and it was all types of cannabinoids that were effective. So this was something that was not specific to a single molecule, but all cannabinoid activators, whether it was CB1 or CB2, were beneficial. So this is very strong preclinical evidence to support the clinical data that I've talked about, that cannabinoids are effective in animal models of gut inflammation. And these studies have looked at a variety of different endpoints. I've just shown you the table on disease activity score, because that's what we also measure in clinical populations, but there's been a whole host of other things, other endpoints that animal studies have shown to be improved by cannabinoids in experimental colitis. So some of the features of these preclinical studies is that you get a reduction in inflammatory cytokines. So there's all of the bad cytokines, all the bad inflammatory mediators like IL-6 and IL-1 and TNF-alpha, these are all reduced by cannabinoids in these animal models. And you also get an increase in the anti-inflammatory cytokines. So some of the chemical messengers in our bodies that have anti-inflammatory actions like IL-10, these are increased by cannabinoids. You get a reduction in the infiltration of immune cells, so white cells kind of moving into the tissue, which can cause damage within the tissue, and that's reduced with cannabinoid use. You get less weight loss, which we saw a signal for in some of that clinical data that showed that people with IBD had an overall weight gain over a year. This is something that's been observed in the animal studies as well, is that the animals lose less weight when they are treated with cannabinoids. And it's also been shown in animal studies that there's reduced intestinal permeability, so stopping all those bacteria and those bad toxins from getting into our bloodstream. And just overall, there's reduced tissue damage. So that picture I showed you at the beginning of the inflamed gut, very red and sore looking and thickened. So that's all reduced by cannabinoids. You have far less inflammation and far less tissue damage. And you also get normalized smooth muscle activity. So the hypermotility, which is associated with these models where the guts are very active and the muscles are very active, and that can lead to very abnormal bowel movements, is normalized by cannabinoids. So they're all the beneficial effects of cannabinoids. There is a major role for the CB1 and the CB2 receptor. Again, just reminding you of how highly expressed these receptors are in the gut. Some evidence that we have to show that there's a major role for the endocannabinoid system in gut function is that if you knock out those receptors, so if you genetically delete the CB1 or CB2 receptor in animals, they get really bad intestinal inflammation and damage, and that tells us that the endocannabinoid system is protecting against gut inflammation. So any types of CB1 or CB2 activators, be it synthetic, plant-derived or endogenous, are all beneficial in the gut. So as long as you're able to activate those receptors, and it doesn't have to be both of them. Some CB1 selective compounds have been shown to work, and CB2 selective compounds have been shown to work. But activation of either of those receptors by any type of compound is beneficial in the gut. And upregulating endocannabinoid tone by inhibiting the breakdown of endocannabinoids by blocking the enzymes that normally break them down, that's Fa and Magl. Any kind of upregulation of endocannabinoid tone, so just upregulating the cannabinoids we already have in our gut, is also protective. And CB1 and CB2 antagonists, so receptor blockers, have been shown to block these beneficial effects of cannabinoids in the gut. So altogether, this is very kind of strong evidence that it is CB1 and CB2 that are mostly driving the beneficial effects of cannabinoids in the gut, with some contribution from other targets as well. So some of the other targets that have been implicated are the TRPV1 channel. So this is the one that we've already talked about in terms of the mechanism of action of cannabinoids in pain. They're very important in the transmission of pain, and they've been shown to be involved in suppressing pain in the gut in IBD models as well. And then the nuclear receptor PPAR alpha has been shown to be very much involved in the regulation of the inflammation in the gut. And so cannabinoid activation of this nuclear receptor brings about the anti-inflammatory effects through PPAR alpha, and also through these other receptors, GPR55 and GPR119. So it is a whole host, and this is the beneficial thing really of cannabinoids, is that they bring about a response, but it's not just through a single target. There are multiple targets that kind of help this compound work. So it's basically attacking the problem from multi-directions, so activating lots of different receptors, all of which have a beneficial effect. So the sum effect is good. So I'm going to move on now and talk about the use of cannabis medicines to suppress nausea and to stimulate appetite. And this is specifically in non-cancer settings, because we're going to talk about the use of cannabis in cancer and for symptom management in cancer in the next lecture. So The reduction in nausea and stimulation of appetite is an area in which we already have approved medications. So there are 2 THC-based medications that have licenses to try and manage these symptoms already, and these are dronabinol and nabilone, which are 2 forms of THC. So dronabinol is just a synthetic version of THC, and nabilone is just a slightly modified, a slight change in the molecular structure of THC, but it's effectively THC. They have very similar actions. And what's highlighted in red is what's relevant for this current lecture. So dronabinol is approved by the FDA for the use in both HIV and cancer for the anorexia, or the reduced appetite and weight loss that are associated with those disorders. And then in other countries, like in Belgium, dronabinol is also licensed for the wasting, and by that we mean weight loss and appetite loss in AIDS. Same with nabilone, and nabilone is specifically more licensed for the use of chemotherapy-induced nausea and vomiting, but it can also be used for other indications off license. And so the fact that we have these licensed medications tells you that we must have a good literature base behind this, because you only get licensing, you only get approval for a medication when it has been proven through large phase 3 clinical trials. If you think back to the lecture that I gave you on the kind of drug discovery pipeline, you only get to that approval phase when it has been well proven that your compound works in that indication. So what is the evidence, for example, in HIV, because we're going to talk about cancer in the next lecture? What is the evidence in HIV that led to these THC products being approved?